This is the NCCN guidelines. You guys have all seen these before in one way, shape, or form, right? Maybe not necessarily in esophageal cancer. So a caveat to this, when I was working on this over the weekend on an airplane, I did not read through these like I wanted to or like I planned to. And I'll tell you why. If you look down at the bottom, these were just updated a week and a half ago, almost 2 weeks, no, 2 weeks ago now. So, and I didn't know they had just gotten updated. I didn't know they were going to get just updated. So what I'm going to tell you may not be 2 weeks old, correct information. It might be a little bit older than that, but I don't think they changed that much. Otherwise, I would have already known they were changing. So when you look at these NCCN guidelines, breast cancer, stomach cancer, colon cancer, whatever, how are they pretty short or are they pretty long? How long is long? Okay, you know how long this one is? 163 pages. This is one of the longer ones. And it's not just because whatever, like it really, there is a lot of detail that actually matters in a lot of things. So when you look through all these, so these are all the people that worked on them from all the different places. These are I think there's like, don't quote me, I want to say there's like 22 places that make up the National Cancer Consortium, or comprehensive, whatever, their NCCN thing. And then it starts having all these links in here, right? And you can go through and you can look at, you can go through the guidelines, the squamous cell, the adeno, combined. You can actually have both cancers, some of the follow-ups, and. And when you start looking through all these things, then you get to these little branch points, right? I think these are the hardest guidelines to read. I think they're designed, whoever designed them didn't talk to me because I would have done them differently. But the concept is good, right? It starts off with some sort of workup, some suspicion for something, and then it starts branching out. But because it's on a PDF or because it's on a Word file, these get like really confusing really fast, and you can't like figure out where these branch points become, right? So hopefully, I'm going to talk in very general terms, but again, these are the details that we're going to talk about. We're going to talk mostly about the surgery for how you do these things. Less about the workup, more about the surgery. This is a surgery lecture, quote unquote, right? So there's chemotherapy regimens, there's immunotherapy, and I know like Dr. Crow, Dr. Freeland will get all excited about those kind of things. I don't care. Here's my other way to, again, save brain power because I'm not very smart. What is the esophagus? Which system is the esophagus part of? The GI tract, or the GI system, right? How different, I know there are differences, I know that, I get it. But how different is the colon from the small bowel, from the stomach, in terms of cancer management? They're similar. How similar? Extremely similar, right? How far of a resection do you need on both sides of a cancer? 5 centimeters in each way, right? So how far do you need on an esophageal cancer? 5 centimeters, right? The only thing that's different on the esophagus is the serosal layer, right? Otherwise, it's pretty much the same. So what kind of chemotherapy regimens do you use for colon cancer? So how different do you think that is in the esophagus? Not. Do you have immunotherapies you can use? What about in the esophagus? What kind of immunotherapy, like what's one of the targets for colon cancer? PD-1. Do you think that's also going to exist in the esophagus? So again, we're not going to spend a lot of time on that. You guys know those things better than I do. And I don't care. How do you, if you have somebody really quickly, well, all right, let's do a case. Let's see if we can pull some of these things out. We're going to do one case, and I promise it's not hard, but who wants to volunteer for said case? All right, you're the man. I know your name. Connor, right? Yeah, there you go. All right, here you go. You're given a 63-year-old white male who complains of progressive dysphagia to solids and a 35-pound weight loss for the last 3 months. Roughly, what are your concerns? The answer is cancer, because that's what we're talking about today. But how are you going to work him up, and what are your initial thoughts or concerns?
So another weight loss.
Okay. Okay. Why are you concerned about those things?
So the weight loss, because there'll be nutritional.
Very good. Okay.
And the progressive dysphagia can be good.
Very good. All right. So how are you going to work this guy up?
So he
very good.
Hopefully with biopsies.
Okay.
Potentially in the US if they do that.
Okay.
An alternative as a first step might be a variant swallow.
Very good.
And then he also would need a CT scan to check out the public.
Okay.
If there's any concern for metastatic disease, it's locally advanced, and I would also want to count them.
Okay. All right. So you get an EGD, and roughly, I'm just making these numbers up, sort of. You get an EGD, it shows a lesion roughly at the GE junction, about 40 centimeters from the incisors. So one thing we didn't mention on here, the length, the mouth to the beginning of the esophagus, or your incisors to the esophagus, adds a few more centimeters, right? So that's not considered the esophagus, but that'll add some length, right? So if it's 40 centimeters, it's pretty much the end of your esophagus. Very good. Let's see here. 40, so that it shows a lesion at 40 centimeters from the incisors with proximal extension. It starts at 38 centimeters. The biggest portion is at 40 centimeters, and it goes into the cardia of the stomach about 1 centimeter. So on biopsy, there's moderately differentiated adenocarcinoma. So that's your EGD. What else did you mention?
EUS.
EUS. You didn't say that at the beginning. You cheated. That's fine. Did you say EUS at the beginning? Okay, fine. All right, fine. So on the EUS, I lied. My bad. An EUS, so your lesion invades the muscularis propria. We talked about that one, right? Very good. It only invades the muscularis propria, and there's no evidence of suspicious lymph nodes. The CT scan, there was no evidence of distant disease. You, by the way, got a PET scan because it's really silly if you're suspecting cancer, just as a general statement, especially esophagus, to get a CT scan without a PET scan. You can do both at the same time. But you don't see anything on the PET scan or on the CT. No, nothing lights up. The CT scan has no suspicious nodes. What else did you say? The barium esophagram, the EGD, the CT. That was all you wanted, right? Any other lab work? Anything else you want to get?
So I want to get a CT.
Okay.
Yeah, I'm not sure.
What's the #1 predictor of mortality in a general surgery patient? Very good. So you should get an albumin. That may or may not come on a CMP depending on the hospital you're in. So what's your concern? You've already mentioned you're concerned about his nutrition status, right? So you're concerned that that's going to be low. All right, very good. So you could argue to get nutrition labs, whatever, but that's kind of not the point today. Okay, so let's talk about staging. So what stage? I'm gonna skip over this because. All right, so we already talked about that. So staging, what's his T stage? T2, why is that? Very good. So why did we go over all these layers at the beginning? Because these layers matter, right? So your T stage is totally dependent on the depth of invasion. Is that the same thing in the colon? Again, concepts, it's the same thing. So here you go. On the left side, you have the T staging for your tumors. So T in situ, I hate that term, but high-grade dysplasia. What is a potential other name for that in an esophagus? Barrett's esophagus, right? All right, so T1, and then it's broken down by all these different, by these different portions. So the muscularis mucosa is a defining point. So on an EUS, and I should have put a picture of this, and I realized I'm sorry. If you do an EUS, you can actually differentiate these layers, and that's how you get these staging points, right? So T2, it goes through the muscularis propria. T3 is into the adventitia. So again, there's no serosa, so it's a T3 on a colon cancer. Roughly. What's that? Into the serosa, right? So we have no equivalent there. So then a T4 has gone all the way through and it goes into nearby structures. How hard do you think that is in esophageal cancer? Not very hard, right? Again, a serosa is, I view a serosa and like there's like certain barriers, right? The basement membrane, like that's a barrier. The serosa is kind of a barrier. That's not there. So it goes, once it gets past there, it's pretty easy for it to keep on going. So those are the T stages. Excuse me. One thing, and back to our basic science, we sort of hinted on this, but where you said it, Michaela, right? Where's the lymphatic drainage? In the submucosa, right? So is it very hard? We understand how cancer spreads. You know, each one is a little bit different. But is it very hard to get to the submucosa and get into your lymphatic system? No. So that becomes uber important here for lymph nodes. So there's your T staging. Your N stages is number of nodes. Pretty similar to GI cancers, right? Similar concept, please. And metastases, anywhere that it goes distant to outside of the N and T staging, right? So lung, liver, whatever. And then here's these are broken down by your cell types: squamous cell, adenocarcinoma, staging. Again, I look these up every time because honestly, it's not worth my time to memorize this stuff. But again, conceptually, at what point, like where did things change as far, so there's surgery, chemo, radiation, right? Where did things change in your only has to have surgery kind of concept? Conceptually, where do you only have to have surgery? T1, why? Why? What's the important point there? You're correct, but what's the important point? But why do you need to give systemic therapy? Very good. So the lymphatic spread. So again, how easy is it in the esophagus to get into the lymphatic spread? Anything more than T1 pretty much is going to need some sort of systemic something. So when do patients often present? Do they present at T1s? Good luck. If you get one, perfect. Like this is a sort of a good setup, sort of. But they usually present late in the game, which is unfortunate. All right, so that's staging. I don't want to spend more time on it than that. Very good. So NCCN guidelines, we talked about that. All right, so let's go back to our case. All right, so we know, what did we say? This is to the muscularis. It's a T2 lesion. Very good. So what do we want to do for this guy? We can move on to the next one. You're next. What do you want to do for this guy? He's got a T2 cancer. Okay. Okay. Do you want to do anything else for this guy specifically? Okay. Okay. Why do you want to do that? Okay. Why do you want to feed him now? You're not going to take him surgery for a while. You just said you're going to do chemo radiation, right? Which is correct. So why are you going to feed him now? Who cares? You're not going to do surgery for a while. To get him prepared more for surgery, but also and what's that going to do to his already quote unquote poor nutrition? It's going to make it worse, right? So he mentioned you're going to use the feeding jejunostomy, and we'll go back to that in a little while. That's correct. So do these patients, this is a trick question, and it's hopefully obvious. These patients usually end up with multiple surgeries, right? Multiple surgeries. So, all right. So we're going to do some systemic chemo RT. We're not going to talk about the types of chemotherapy because that's really, I find, boring. All right. So we're going to talk about different types of surgeries for these. So before we go to surgery, how many types of a surgery are there for an esophagectomy? Who knows? 3. You could argue there's actually 4. What's the 4th one? Oh, all right, 5. That's a correct statement. But what else could you do? If you have somebody who has a TIS tumor endoscopic, right? So GI does that. Some surgeons do that. We're not going to talk about that. But basically, if it's a super superficial one, they can go in and just scrape it out. I'm not sure how they, whatever, it works. All right, so there's a classification in terms of how you're going to figure out which surgery to offer these people, right? So first of all, there's surgeon experience. You can pick and choose based off of what you're comfortable with, but there actually is a classification. Does anybody know what it's called? For how you decide which surgery they're going to do. What is it? Seward, I don't know how you say it, but Seward, something like that. Seward, whatever. So some guy named whatever proposed this in 1987, and he based it basically on where the tumor is in relation to the GE junction. So I don't know how you guys can see that, but there's this type 1, type 2, and type 3. So at your anatomical cardia, right? This is not related to mucosal layers or pretend layers or this is like a quote hard line, right? So basically at the diaphragm is how he defined these differences. So a type 1 is anything from a centimeter above that north. So what is roughly the extent to which you can do, if you had a tumor, how high can you take out a tumor? How do I ask this question? What is the most proximal distance you could do an esophagectomy for a patient with esophageal cancer? 22 centimeters. What is? I'm not going to argue the distance, but why that point? Why do you say that? Why? Very good. So you need margins, right? You want to have an R0 resection. The only way that you can get margins that high, you cannot actually make them have a functional tube anymore. So it's up too high into the chest or into even the neck to get appropriate margins. It's not necessarily on putting it back together, but it's on taking out what you can take out. So roughly, if you're looking in somebody's chest, where is that roughly? That distance where the cancer has to be below. There's a great landmark. It's actually written on the board over there. Nope, that's way too high. That's chemorad. The azagus, who said it? Very good. So if it's above the azagus, you're pretty much not gonna be able to take that out surgically. That's gonna be chemorad. That's a rough, obviously that's an inside the chest measurement, but. All right, so type 1 is 1 centimeter proximal to your anatomic cardia and above. A type 2 is between 1 and 2 centimeters below, and then a type 3. I really think of a type 3 as a GI as a gastric cancer. It's technically a GE junction cancer, but G comes first in that part. So again, they're not treated differently though. But it's just it matters in terms of what your surgery, what you're going to do. So type 1 tumors, as a general statement, behave more like distal to mid-esophageal tumors. So which direction are you going to have, where are you going to look for your lymph nodes in this case? So talk to all these, again, all these points are all going to start coming back. How is this cancer going to spread if it's in a type 1 GE junction tumor? I should have said this really only applies to GE junction tumor. Which way is it going to, where are you going to look more predominantly? Anyone? Inferior, right? So it's going to drain towards the GI system, your lymph nodes, your liver, that kind of stuff. If it's above this point, where's it going to go? Mediastinum and neck potentially, right? All right, so risk factors, smoking, obesity, Barrett's GERD. So really these ones that can actually go both directions, the type 1s, but the risk factors, there's some people that argue these risk factors sort of change. In America, what's the most common esophageal cancer now? Do you guys know? Adeno. It used to be, when I was in medical school, it used to be squamous. What would you think, what would the change be? Smoking is actually what it used to be, right? The biggest risk factor, but now it's obesity is a bigger risk factor. So worldwide, it's still squamous. In America, we've gotten fat and lazy. All right, so type 1 tumors, they can kind of go both directions. Type 2 tumors, really not associated with anything. They kind of do on their own. They go south. I call down the south. Type 3 tumors, again, I say these are more like a gastric cancer. I don't know that honestly I've ever been involved with a type 3 tumor. All right, so there's three different types of surgeries, right? We mentioned. So there's a endoscopic mucosal resection, or EMR, right? Not a health record, but an EMR. There's an Ivor Lewis. What's another one? I've cheated. I put that one up there, so it doesn't count. Trans-hiatal. What's another one? A 3-hole. Do you guys know a name for a 3-hole? A McKeon. And then there's the total left, right? And that's kind of a weird thing that really nobody does, but those are the 3 different types of surgeries, right? So let's talk about an Ivor Lewis. So an Ivor Lewis is a 2-hole surgery. You guys know who Dr. Ivor Lewis was? He's a British guy. It's actually one guy's name. It's not 2 combined. He was a British surgeon. So long, long ago, the British used to be the best at it. He was a quote rival with Belzy. You guys have heard of Belzy. So he came up with his own way. Belzy went from the left chest. He decided he'd go from the right chest. Oh, one other thing we didn't talk about on here on the anatomy. So let's see here. Who wants to be tribute for this? We'll just do raise of hands. The cervical esophagus, which side of the body is it on? The left side. Your thoracic esophagus, where is it at? The right. And where is the abdominal? The left. Where do they switch back and forth? Anybody know? Here's a really safe answer. And anything in the chest, it all moves across at the carina, or at the second intercostal space, or the angle of Lou, right? If you say any of those, you're probably right. It's like saying something comes from anyway, never mind. But anyway, that's where they pretty much cross, and then down just above the diaphragm is where it switches back, right? So Ivor Lewis said, well, why are you doing surgery in the left chest if it's all in the right chest to start with? So that's how this all came up with. So the points of an Ivor Lewis, it's a 2-hole esophagectomy, trans-abdominal and trans-thoracic sections. You can do these laparoscopic or thoracoscopic, robotic, whatever. There's all kinds of variations on the theme. You use a gastric conduit. You do a mediastinal lymph node dissection. So what are the benefits? When would you do this? And what C-word class, 1, 2, or 3, would you do this type of surgery? More distal? The answer is all of them, right? This is kind of you can do it all with this one. So there's the four of you that raise your hand if you've seen this again. I'm sorry, I'm gonna call on you guys mostly because you've seen this, but I don't expect you to know these details. I don't know your name. Olivia, you're next. So what is, and everybody should know this because this is on your board, on your in-training exam and your oral boards. So we talked about blood supply, right? The blood supply to the abdominal esophagus is the left gastric, right? So if we're going to use a stomach, oh, well, let me go back. What are some options here? You get an easy question. What are some options to replace? If we take out an esophagus, what happens if you don't have an esophagus? You die, right? Because you can't then get nutrition, right? So you have to have some way to get nutrition. So you have to have a plan for if you're going to take this out, you better have a plan, right? So we talked about giving him a GJ tube for this case. Fine, that's fine. So we don't just take things out. We try to replace them, especially if they're necessary for life, right? You can take out part of a colon. Colon's, who cares? Colon, you don't need a colon. You can take out part of an esophagus, but you better recreate it or have some other plan, right? So what can you use to recreate an esophagus? Okay, what's another option? Okay, what's one more option? Which is the worst option, and I don't know of anyone who's actually done it. Very good. Technically, you can actually use a rubber hose too. That was the first one that was ever done. Because what's an esophagus? As much as I say it's life necessary, I'm not kidding. I mean, like a garden hose. It's a tube, right? There's some peristaltic action. There's some things that it does, but it really is just a tube to get food from your mouth to the part that absorbs it. Not much more complicated. So really, the first one was actually a garden hose. Anyway, so you're going to tubularize your stomach. You can use a colon. You can use a. So when you do those kind of maneuvers, you need to preserve blood supply, right? So what's going to be the important blood supply if you're going to tubularize your stomach? The right gastric. So how do you prepare your stomach? How would you do that? Okay. I'm sorry, we said right gastric. It's right gastropapilloic is technically the book answer, but it comes off your right gastric. So here's a picture. Now we can turn, who had the lights? Can you hit those lights? I'm not sure how well you can see that, but so she just mentioned all the points for this, right? So you're going to tubularize your stomach. You want it to be roughly about 5 centimeters wide from your staple line to the edge of the stomach. And it's going to, I love when things say gentle retraction. This makes me laugh. Of course, you're going to be gentle, but that also implies that you don't do it hard enough. So your right gastropapilloic artery is going to come along here. So you divide all these other branches. So how many blood supplies does the stomach have? I don't know, but it's a lot, right? So the stomach is pretty robust, and you're going to take out most of them actually. But the stomach is pretty cool because it can survive off of just one of like its 5 different blood supplies. So I trained at Ohio State, there were when we did these, we would actually take them to the OR. When we talk about multiple surgeries, they get their GJ tube or their J tube or whatever they were going to get, usually a J tube. We take them to the OR, do that, and then a week before we plan to do our esophagectomy, we would actually go through and devascularize the stomach to see if we could plump up and make that right gastropapilloic a little more robust. Kind of a cool little trick. Anyway, so you create a conduit that you're going to do that with. So like I said, about 5 centimeters long, you're going to tubularize the stomach, right? So the portion on this, you can see my little pointer, this is all going to be resected, and then this is going to connect it. So just a couple of points on here, and I hate talking about GI surgery because I don't like it very much, but is that going to reach, so depending on the proximal portion of your resection, right? How far up do you think you can make that tube of a stomach reach into your chest? What's that? You actually get it pretty far. But what are some maneuvers you can do to help you? Pokerize the duodenum, right? So you're going to try and make it so that's as mobile as possible. I think you should do that every case. That's my own opinion. Because again, why set yourself up for failure? But that's the feared complication of this is a leak. Just going to get that out there just so nobody misses that. So what are the things that lead to leaks in GI anastomoses? Tension, what else? Ischemia, what else? Nutrition and infection, right? So all those things are like terrible disasters, even more so in this. So you're going to have potential for a lot of tension here, right? So if you take your resection, this is why some of these other things will come up as important details. So I believe personally, you should cocarize the duodenum, get as much tension off of there as you can. What else do you have at the end of your stomach? Pylorus, and what does that do? That can become an obstruction too, right? So I believe, again, this is my opinion, that you should probably do a pyloroplasty on all these. Again, just to help you, because why set yourself up for success or for failure? I mean, so you pull your stomach up into your chest. Let's go back one picture. Again, you can do this laparoscopically, however you want. You take off a lot of the omentum. That's going to help give yourself some room. You're going to preserve your blood supply. You're going to divide all of your gastrosplenic ligament. You're going to pull that up into the chest. So then you're going to have a chest portion of this procedure, right? So these are placements for ports in the chest. And again, there's 100 different ways to do this. You have to, a couple conceptual things when you're planning these out there. You need to, that patient needs to be flat for the abdominal portion, right? Now you've got to put them in a prone position, or I'm sorry, in a lateral decubitus position. So you're gonna have to rotate base. So you have to like finish, close the belly, roll them on their side, start all over again. So it's kind of like it can become a long process. Then you do your anastomosis. I have only done one hand-sewn anastomosis in the chest. Everything else has been with a gastroesophageal stapler. Kind of a cool technique to do that with. And again, you're going to worry about blood supply here. You're going to worry about leaks, infections. Is it better to have a leak in the chest or the abdomen? I agree. I personally agree. A chest is fairly easy to manage, fairly. They're sick patients, but the concepts are not very hard as to how you do that. All right, so what's another type of, that's the basic principles of an Ivor Lewis. Any questions on that? All right, what's another type of surgery that we can do? Transhiatal, good, that was actually the next one up. So what is a transhiatal? What's different about a transhiatal than a Ivor Lewis? The second hole's in the neck. So how do you get that section out of the chest? Bluntly with your hands. All right, so that is 100% correct. So what allows you to do that in this case? It's on the board. If you're going to take out something, you have a structure, like if you're going to take out the stomach, could you take out the stomach bluntly with your hands? No, why? Blood supply, who said it? Very good. So what's the blood supply in the thoracic esophagus? There are little branches, right? Can you just muscle through those? Pretty much. As crazy as it sounds. They retract right in and they don't really bleed. So the blood supply to the central portion of the esophagus is pretty weak in the grand pictures. So this is what it looks like. So you literally you do have an abdominal incision. This is when it's very rough to do laparoscopically. You can do it. And there are people who have described it, but it's very rough and it's honestly by feel. This was invented, or the guy that came up with this was at the University of Michigan. And he was very vocal in his beliefs that this would work. He said you could do this every single time. So really quickly, which types of esophageal cancer could you do this on? All of them. You can do this on all of them. Except for really high ones. It's much more of a challenge, really high. That's something they learned over time. So the guy that invented this, Oranger's his last name, he was very vocal and said that no one should ever go into the chest for an esophagectomy. The only contraindication was if your hand couldn't fit through the hiatus. That was his belief, and he really stuck to that. So if your hand's too big and you can't get it through the diaphragm, that's probably a reason why you can't do it. But honestly, you can really get everything. So you mentioned the other hole is in the neck, right? So what does that imply? The cervical anastomosis. So the other implication is you better have done everything in the belly, I believe. If you're going to do an anastomosis in the neck, you've got to do all of those things we talked about. You got to cocarize things. You've got to make as much space as you can, and you better have a really robust blood supply to that conduit, because otherwise you're going to have some serious potential for leaks. So which place has the highest, which anastomotic location has the highest leak rate? The neck. Which one is the easiest to manage? The neck, which is why a lot of people advocate for doing it in the neck. How would you expose the neck in this case? There's a little picture of it sort of in the corner. But how would you, so you make your incision along the left. Very good. So you have to go, it's beneath the carotid, right? So then you divide your esophagus and then you sew that back together. Would you leave a drain? Almost always. Again, they draw this in here. You want to really make sure that you get a good pyloromyotomy, do pyloroplasty if you need to. You're going to have to divide some of the hiatus to get your hand up there. Your hand goes all the way, by the way. You can reach, but your hand, you're pretty much elbow deep in this person's with your arm. Oftentimes these are more hand-sewn anastomoses, and I think that's more just because of the historical part and the limitations on the stapling device, but you can get that whole thing up there. This is one you don't have to reposition the patient halfway through surgery, so it's kind of nice in that terms. You can do them fairly quickly. If you like, I kind of breeze through this, but the esophagus sits in this plane, right, of normal areolar tissue. The blood supply is pretty weak. We didn't talk about this in our anatomy, but where does the esophagus sit in the chest? If you took like a CT scan and looked at it, where's the esophagus roughly? It's in the back, right? It's next to the aorta. So then if you're putting your hand up there through there, what's the implication? What's above your hand? The heart, right? So if you're doing this in the wrong, if you're in the wrong plane, you can get into some big trouble really fast. It's very hard to do that. And then a feeding tube. Let's see here. What else do we say? If you, the tricky part when you're making if your stomach, if your gastric conduit is got tenuous blood supply, you really are in big trouble. One of my first days as a fellow, thankfully I wasn't involved with the case, but they had their blood supply was not robust enough to the stomach, and he died actually. He ended up getting super sick, and his anastomosis fell apart, and his stomach, the conduit was dead, and you know, it was rough. All right, McKeon esophagectomy. So we said this is a 3-hole. Sorry, I'm trying to cut back and go really quickly here. This has the benefits of all of the above. You can do everything. You can see everything. It's got a neck anastomosis. So what do you do these for? And Ivor Lewis is for 1 or 2. It's really not very good for something above the chest, above the carina, or above the azygos. They're all in the same neighborhood. Mostly because your anastomosis or your dissection stops there. A McKeon is great for a 1 and 2. The trans-hiatal kind of can do all 3. But again, 1 and 2. Minimally invasive, you really can't do a minimally invasive transesophageal. That requires an open. I mean, there are some people who have been able to get up high enough, but really that's pretty tricky. The cervical, like we mentioned, has a higher leak rate. Sorry. The thoracic has a higher morbidity with a leak. So which one do you do? This is some old information, but James Lukatich from Pittsburgh compared a minimally invasive version of a McKeon and an Ivor Lewis. They're pretty similar, actually, between an open. D'Amico, this is out of Duke. Again, these are somewhat old, but there's really no difference between minimally invasive and an open esophagectomy. What other questions can I answer? Very good. No other questions? All right, so just again, back to this really quickly to our NCCN guidelines. These, I know I kind of bagged on them for 163 pages. And it is hard to read because there are so many pages, but squamous cell adenocarcinoma are a little different, only in terms of their staging. And I showed you that, kind of implied that with that slide. They're a little bit different. Your recurrence, it does come back. A lot of these patients often start off unresectable, which is pretty crappy, right? So there's your ECOG status, all those kind of things that determines resectability or not. A lot of them just go straight to definitive chemoradiation. And that's because, again, we talked about they've already spread. It's invading other tissues. So T4, we didn't really talk about, it invades other tissues, but if you think about where the esophagus is, a lot of those are not necessarily resectable tissues, right? I also believe, just as a general statement, you should, you don't necessarily need to do this at the beginning of your workup, but they should get a bronchoscopy at the time of their surgery, at least. That was one of my general surgery oral board questions. And thankfully I was in the middle of my thoracic fellowship, so I was like, sweet, great way to start. But if they're having any airway issues, obviously you need to know about, you should do a bronchoscopy sooner. But at the time of surgery, you should do a bronchoscopy, because if it's invading the trachea, you're done. There's nothing that you can do surgically to fix that. An R0 resection, again, great. You're going to end up just surveilling them. An R1 resection, they're going to end up with chemorads. An R2 resection, you're going to end up with chemorads. You probably failed if you got an R2 resection out of a esophagectomy, because you probably missed something in your workup. Again, these go on and on and on and on. But again, just a couple key points. So number one, nutrition status. Don't screw up your stomach conduit. Please, please, please don't screw up your gastric conduit. I've personally never been involved with something that wasn't the stomach. It can be done with the colon. It requires a microanastomosis with the blood supply off of your left colic anastomosed onto something. So you end up with blood supply anastomoses as well as proximal and distal anastomoses. So you got multiple things you really become stressed out. In your post-operative management, you really, really, really try and avoid pressors, because you don't want to clamp down on those that tenuous blood supply to start with. So the answer is almost always volume at all costs. If you can avoid giving volume. The tricky part is now you've gone into the chest, or you've done something in the chest, and so there's going to be all those complications. The problems that run in chest organs are often the same problems that run in esophageal patients. They're usually smokers, so not always, but they tend, they're obese. All these things that you worry about in surgery in the chest, you worry about them that much more in the esophagus. Leaks are fairly common. Knock on wood, when I was at Ohio State, we only had that one in my first week, but we never had one again. But they happen frequently. We did a lot of esophagectomies too, which is pretty awesome. We only had one in my 2 years. The management of them is symptomatic management. You try and avoid going back in if you can, but sometimes you have to clean things out. And if you have to divert them, that's a pretty rough thing to do, but sometimes you have to divert them and give them a neck stoma, and then feeding tube in some way, shape, or feeding options in some way, shape, or form. Probably is not going to turn out very well. We managed a couple of others that got referred to us for that, and those usually do not turn out well. If they're that sick that you had to divert them, they probably are not going to do very well. Again, chemo radiation, platinum-based kind of stuff. Immunotherapy, HER2 is a big one in esophageal cancer as far as immunotherapy and markers. But otherwise, like I said, it really is another GI cancer, just in a different location. So you don't have to be too scared in terms of knowing lots of different things. Obviously, each thing has its own fine points. But no other questions? Yeah. So that's a great point. So I said earlier, the number one predictor of mortality in a general surgery patient, or all surgery in all comers, is an albumin, right? That's less than 3.5, so it's a fairly normal number almost. If you're doing surgery in the chest, the number one predictor of mortality is a DLCO of less than 60%, which is not necessarily normal, but it's a lot higher than you would think it is. So these patients, yes, PFTs are, if you're going to really do something in the chest, you really need to make sure you have a thorough evaluation, because again, these are all the same patients that have heart disease, that have lung disease. So that's a great point. With the caveat, with the transhiatal, some of those get kind of washed out a little bit. But yep, you can try all those things. None of them are great. When there's lots of options for something, it probably means there's not a really good one. And that's a true statement. I've used omentum flaps. As you pull up your stomach, you kind of keep a little tongue on there. I've seen intercostal muscle flaps. You just have to make that plan at the beginning of the case, because at the end of the case, if you're like, oh crap, we should have done this, it's too late. So harvesting an intercostal muscle at the end is not really possible. Same with an omentum flap. All right, any other questions? Very good. Thanks, guys.